A very good morning to all of you. First, I would like to thank organizers Kavina Creation, Urvish Parik sir, and Chandrakant sir for giving me this opportunity. So I'll be starting today's session with the topic of tissue storage and transportation. So basically, tissue processing. So this is mainly a pathologist topic, and I will be presenting from medical oncologist point of view. So why this topic has been chosen for today's discussion? The reason behind that is the rapidity with the field of medicine is evolving. So in the past, we used to practice intuition medicine. That is, we used to treat patient based on the individual knowledge of physician and his experience. Presently, we treat patients mainly on the evidence-based medicine. That is, we treat patient based on the results of scientific research and clinical trial. And slowly, we are moving towards future, that is precision medicine. In precision medicine, we treat patient based on their own tumor characteristics, that is their mainly genomic and epigenetic profile. And for practicing precision medicine, we need to do more and more testing. So as we are moving towards precision medicine and our testing requirement is increasing, the requirement of tissue is also gradually increasing, and that's why nowadays tissue has become an issue. And there is always a difference whenever we order a tissue for the biopsy, that is for examination, the ideal sample size we expect is actually different from the reality. In reality, the sample we get. So that's why we need to handle the tissue in a optimum manner, in such a way that the whatever the amount of tissue is available for us should be available for maximum amount should be available for the testing, and we don't waste the tissue while processing. So this is a slide showing how the journey of a sample happens after the first step of biopsy. That is the biopsy when done by the interventional radiologist or the pulmonologist, or when a sample is taken for the surgeon, which is the first step. It goes to the second step of pre-analytics, where the tissue is processed for or prepared for the further testing. And in the third step, when the sample is optimally processed, the diagnosis is done by the histopathologist based on the microscopic examination. And as per the report of the pathologist, as a clinician, further order the test, specialized test like ISC or the molecular test, so that we can treat our patient with the best possible treatment available for that individual patient. So in short, the tissue handling process for the purpose of diagnosis mainly has two workflow, that is pre-analytic and analytic. So we as a clinician or the medical oncologist mainly focused on the analytical part, that is which patient needs to be treated for, need to be tested for which test, that is which molecular test or which IHC test. But pre-analytic, that is tissue processing, is mainly a domain of pathologists. But nowadays it has actually become a topic of great discussion in recent years, due to the fact that the workflow step for pre-analytics has largely non-standardized, and there has been variability in the workflow step, which is followed by different laboratories and in the different centers. And this variability, and that is the poor pre-analytic methods, can lead to many errors, like mislabeling of the tissue, improperly fixed tissue, that is underfixed or the overfixed tissue, or the tissue contamination. Again, there is a data from MD Anderson Cancer Center, which was published almost 11 years back, and they have clearly shown that the inconclusive rate of HER2 testing decreased from around 10.8% to 3.4% after improving the methods to regulate the fixation time. Again, there is another study which specifically focused on the effects of pre-analytic methods to IHC, and found that there were almost 15 pre-analytic variables that could have impact on stain intensity and the quality. And that's why the proper tissue processing is very important. And there is a need to develop new pre-analytic tools and technologies for standardizing the tissue collection and reducing the errors in the histology laboratory. Modern pathology is mainly built around the principles of preserving tissue in such a way that in vivo molecular status is maintained at the representative of disease state, so that we get the accurate molecular results when we request this test to be done in a specific patient. So now I will move to the score of our presentation, that is tissue processing. So there are mainly 7 steps of tissue processing. So first and the most important is the fixation. The next is the dehydration. Third is the clearing. Fourth is the integration. Then fifth is the embedding and blocking. Sixth is the section cutting, and seven is the routine staining. So I will discuss these steps one by one in the future slides. So first is the fixation. So why fixation is needed? When any tissue is taken out of the body, it will decompose. Like any dead body decompose after death. So reason behind that is the loss of blood supply and the oxygen, accumulation of the product of metabolism, action of the autolytic enzyme, that is autolysis, and the putrefaction by the bacteria. So these all changes need to be prevented, and this can be done by fixation. If we don't prevent these processes by fixation, tissue will be decomposed and we further cannot process this tissue. So fixation is the first and the foundation step of histo technique, in which the tissue is fixed in complete physical and the partial chemical state. The principle of fixation is the denaturation and the precipitation of cell proteins. A soluble component is made insoluble. Prevention of osmotic damage to tissue, because of which tissue may get shrink or swell. So that's why by preventing this, fixation preserves the cellular and tissue architecture in the lifelike state, so that it can be further processed. We have many different fixative available for histopathology laboratory, and every fixative has different properties, and each is indicated for the special purpose based on the type of cell component to be studied and the method of sectioning and staining which are planning to employ. So classification of fixative. So there are a few classification of fixative, like here we can see in the three tables. So it can be classified based on the chemical composition, that is physical agent, aldehyde, coagulant, etc. Then it can be again classified based on the type of structures, the fixative fix, that is histochemical fixative or microanatomical fixative, cytological fixative. And again, it can be again classified on the basis of the number of structure fix, that is simple fixative and the combined fixative. So I will not go in details of this classification because it is not our domain actually. So what are the commonly used fixative? The formalin, which is the formaldehyde 10% neutral buffer solution form, it is the most commonly used fixative, and it is routinely employed in most of the histopathological laboratory. Other commonly used fixative are the glutaraldehyde, which is mainly employed for electron microscopy examination. Then we have picric acid, which is mainly used for the renal and testicular tissue examination. And we have alcohol, that is cornoid fixative, which is used for fixing cytological smears and the endometrial sampling. Then osmium tetroxide, which is mainly used for examining CNS tissue and the electron microscopic tissue. Out of these fixative, most commonly used fixative is the formalin. So what are the effects produced by the fixative on the tissue? So the fixative prevents the tissue from putrefaction and autolysis, which is very important to prevent it from degradation, which I have already discussed. Then again, second effect is it hardens the tissue in such a way that it helps in the section cutting. So without this hardening, we cannot cut the tissue in small pieces or the small sections. Third effect is that it makes cells insensitive to hypertonic and hypotonic saline, hypotonic solutions, which is important to prevent shrinkage and the swelling of the tissue. It also acts as a mordant, and it also induces the optical contrast for the good morphologic examination. So these are the important effects which are produced by the fixative on the tissue. So what is the ideal fixative? So ideal fixative should be cheap and easily available. It should be stable and safe to handle. It should not be hazardous for handling. It should be rapid in action. It should cause minimal loss of tissue. It should not bind to the reactive groups in the tissue, which is meant for the dyes. It should give even penetration. It should retain the normal color of the tissue, and it should not impart its own color to the tissue. So these are some of the important properties of the ideal fixative. And one of such ideal fixative is the formalin. So formalin as a fixative was discovered in 1892 by Ferdinand Blum, which is almost 120 years back. He discovered incidentally this fixative when he noticed that skin of his finger became hardened when it came in contact with the formalin. And since its discovery around 120-30 years back, it is the most commonly used fixative for so many years. And still, after so many years, the molecular mechanism of tissue fixation by the formalin is not well understood. One of the theories is that formaldehyde penetrates between the nucleic acid and the protein, and it forms the stabilized shell of nucleic acid protein complex. One more theory of means how formalin acts as the fixative is that formaldehyde has a reactive electrophilic species which react directly with readily with the various functional group of various biomolecules in a cross-linking fashion, molecules such as protein, glycoprotein, nucleic acid, polysaccharide, and such intra and intra molecular cross-linking of the macromolecules alters the physical characteristics of the tissue and prevents it from the degradation. Although formalin is one of the ideal fixative, there are some issues with the formalin also. If the formalin is not properly buffered, prepared, or stored, formaldehyde in the solution can form formic acid, which can degrade and fragment the nucleic acid, which we want to avoid. Again, various researchers over time has pointed out that there are some limitation with the formalin in that it is slow in fixation, that it takes time for fixation, it has slow penetration, it has poor nuclear fixation, and it can cause shrinkage of the tissue. Again, it may not also assure the complete DNA and messenger RNA recovery, which is essential for many molecular tests, which we are now under continuous development. Formalin again is found to be health hazard. There are studies which have shown that formalin can affect the immune system of the body. It can be hazardous to various systems in the body like respiratory system, GI system, etc. And it has also been shown to be potential carcinogen. So definitely it is a health hazard for the workers who handles the formalin. And to overcome this problem, formaldehyde-free and non-cross-linking fixatives compatible with the paraffin embedding has been developed for routine histopathology, for example, like Glaxol, but it is still not in the routine practice in most of the laboratories because the major hurdle behind that is most of the histopathologists are not well experienced or well versed with the tissue fixed with the fixative other than formalin, and so they are hesitant to use other fixative for routine histopathological processes. So what are the rapid fixation times? So as the more pressure has been placed on the histopathological laboratories to decrease the turnaround time, because most of the time we need our test to be available as fast as possible so that we can start treatment as soon as possible. We need to develop, we need to get the results of the test as fast as possible, and to get these results faster, we need to improve, decrease the fixation time. And there are some of the techniques which are proposed to reduce fixation time. One of this method is just to raise the temperature of the fixative to increase the cross-linking rate. Another protocol is 2+2 protocol, which has been shown to reduce the fixation time from almost 24 hours to 4 hours. But although these are some of the methodologies which has been proposed to develop the rapid fixation methods, but again these methods are not routinely used in clinical practice or routinely in the laboratories, and still the fixation with the formalin done mainly at the room temperature only. So whenever the tissue is taken by the radiologist or the surgeon for the histopathological examination, it is immediately kept in the formalin, which is the most commonly used fixative. And for the fixation, the optimal fixation time is 80 to 24 hours at the room temperature. So this fixation time is very important, because if we underfixed, means we keep the fixative for less than 18 hours, or we overfixed, if we keep the fixative for a longer period of time, maybe for around more than 32 hours, it may affect the morphology of the tissue, and we may not get the proper tissue for the examination, and it can hamper the results of the histopathology. So once the tissue is obtained, it is immediately kept in the formalin and it is sent to the lab. And once it is sent to the lab, it is kept in the formalin for around 18 to 24 hours for optimum fixation. Once the fixation is completed, the tissue is taken out of the formalin for grossing. So whenever a surgical sample is sent to the lab, first thing is done is grossing. So during grossing, the appearance of the specimen is noted. Measurements are taken from the specimen and the tumor which is visible to the pathologist, and any visible pathological changes are also noted. And after that, after this grossing, the samples, bits are taken from the representative area of the tumor, which is generally the bits are taken from the solid appearing areas of the tumor. Now again, care need to be taken while we take these small sections for the histological examination, because if then this section should be not more than 4 mm thick, because if the sample is the samples are taken for histological examination, if the size is more than 4 mm thick, the fixative may not penetrate into the deeper part of the tissue, and that's why some of the tissue may remain unfixed, and which may result in the autolysis of the tissue. And again, so that we will not get the optimum histopathological tissue available for the examination. So this sample procurement is very important, and we should not have thick sample taken while the sample is taken from the tumor representative area. So this is the here we can clearly see how the specimen is kept in the formalin for the fixation, and this is how the grossing is done. This is again how the grossing is done, and the morphology and the all characteristics of the tumors are noted by the pathologist. So once the fixation is done and grossing is done, and the representative tumors are removed from the tissue is removed from the tumor area, a second step is the dehydration. So the dehydration is important because water needs to be removed from the tissue and the cells, and these spaces need to be occupied by the wax. This is important because to prevent the refraction errors. So if the water is present in the tissue, and when if the water is present in the tissue and the tissue is examined by the pathologist in the microscope, it can cause haziness if the water is present because of the refraction errors. So this is very important step to make the slides look clearer to the histopathologist while they examine under the microscope. So for dehydration, the tissue is sent through the graded concentration of alcohol, that is initially 70%, then 80%, then 95%, and the absolute alcohol. So this is the way the dehydration is done, and the water is removed from the tissues and the cells. So one of the most commonly employed dehydrating agent is the ethyl alcohol, and other alcohol which can be used are the methyl alcohol, isopropyl alcohol, and the acetone, which can be rarely used, but the most commonly used is the ethyl alcohol. So after dehydration, next step is the clearing. So clearing is required to remove the alcohol from the tissue and the cells, and it is to be replaced by the chemical which is wax soluble. So this is required because wax is insoluble in the alcohol. That's why we need to remove the alcohol and replace it with the other fluid which is wax soluble. So this step is required to make the tissue look transparent while the histopathologist examine the tissue under the microscope. So the clearing agent which is commonly used by the histopathologist is the xylene, and other clearing agent which can be employed are the toluene, benzene, chloroform, etc. But the xylene is the most commonly used. Then after the clearing, the next step is the impregation. So impregnation is important because empty spaces in the tissue and the cells after removal of the clearing agent need to be taken by the molten wax. So this is required because to make the tissue harden and provide the external support to the tissue. Without this process, tissue cannot be taken up for the section cutting. So this is very important step to provide the support to the tissue so that we can take thin sections from the tissue for the further examination. So these 3 steps of dehydration, clearing, and the impregnation can be done with the help of automated tissue processor. So this is very important because automated tissue processor reduce the time required for these all processes, and it also reduces the manual errors which can happen if these processes are done by the manual processes. So there are 2 types of automated tissue processor, that is open or hydraulic, or it can be closed or vacuum. So this is a slide showing open hydraulic processor, that is open tissue processor. So open tissue processor has 12 sessions, that is one for the formalin, 1 jar for the formalin, then the 6 jar for the graded concentration of alcohol for the dehydration, then 3 jars for the xylene for the clearing, and the 2 jar for the molten paraffin box for the impregnation. So issue with the open hydraulic processor is that it cannot prevent the chemical evaporating from the processors, so that these chemicals can be the hazardous for the people or the workers operating this hydraulic open processor. Again, there is the difficulty in handling maintaining the temperature, pressure, and the vacuum in the open processor. And so to avoid this problem, the closed or the vacuum processor was developed. So in vacuum processor, everything is in the enclosed sections, and there is no risk of chemical evaporating from the processor, and there is no risk or hazardous exposure to the workers handling this tissue processor, and the temperature and the pressure and the vacuum can be accurately controlled with the help of this closed processor. So after all these basic three steps of dehydration, clearing, and the impregnation, the next step is the embedding and the blocking. So once the tissue is impregnated, it is placed in a tissue, means it is placed in the mold filled with the molten embedding medium, which is then allowed to solidify. So most commonly used molten embedding medium is the paraffin wax. So paraffin wax can be placed in the metallic blocks or the plastic molds. So plastic mold routinely we use commonly in the pathology laboratory, but older days we used to use metallic blocks. So when the tissue is placed in the molten embedding medium, that is paraffin blocks, once it solidifies, it forms the paraffin block. So this is how the embedding center looks in the which is commonly used in the histopathology laboratory. So this is how the tissue is removed from the cassette, and it is filled in the mold filled with the molten wax, and how the wax solidifies, and finally it forms the paraffin blocks. So once the paraffin block is available, the next step is section cutting. So section cutting is done with the help of a special instrument, that is microtome. So there are different types of microtomes available, that is rotatory, sliding, freezing, rocking, or base ledge. But the most commonly used microtome is the rotatory microtome. So with the help of rotatory microtome, very thick sections can be taken from these paraffin blocks, where that can be as thin as 25 micron in thickness. So here is the here we can clearly see how the thin sections can be taken with the help of rotatory microtome. And once these thin sections are taken, these sections are placed on the slide, and then they are taken for the routine staining, that is H&E staining. So hematoxylin, eosin is the commonly used staining for the histopathology slide. So hematoxylin is for nuclear stain, and the eosin is used for the cytoplasmic stain. So that's why the nuclei look pink, and the cytoplasm, sorry, nuclei look blue and the cytoplasm look pink. And this is how the slides look after the staining with the H&E. And again, this is the slide how it looks when we stain it with the H&E stain. And this is the slide. This is a slide showing how beautiful the picture of a tissue is seen when it is examined under the microscope by the histopathologist. So in the last presentation, I have outlined the basic processes which are involved in the tissue processing. So here I will specifically address the issues related to the NGS or molecular testing with regarding to the tissue processing we routinely do. Next slide. Next slide. So yes, so I have already discussed in my previous presentation that formaldehyde, which is routinely used as a fixative in most of the clinical laboratory, but when we use formalin or formaldehyde as a fixation, it has been shown to have profound effect on the extraction of DNA and RNA from the tissue. That is not only because of the cross-linking of the formaldehyde with the surrounding histone, but also formaldehyde can directly react with the nucleotides. And this cross-linking and the direct reaction will cause fragmentation and the cross-linking of the nucleic acid, which results in the low quality and low molecular weight DNA. So such low quality DNA is generally not suitable for the whole genome sequencing, but sometimes still might be okay for whole exome sequencing or targeted sequencing. Next slide. So again, the paraffin fixation process can lead to RNA modification and RNA degradation, and it can affect the quality of RNA extraction, PCR, sequencing, and microarray analysis. And most often when we do multiple tests on the already performed paraffin block, sometime at the last only single H&E slides is only available for further testing for a particular patient, which can be actually problematic for further molecular testing. Next slide. So to tackle such issue, newer techniques has been developed. One of these technique is fresh frozen tissue. So I will discuss here what are the advantages and disadvantages of fresh frozen tissue, and also what are the differences, basic differences between the fresh frozen tissue and the formalin fixed tissue. So advantages of fresh frozen tissue is that this process is much quicker as compared to formalin fixed tissue, which takes some time for the fixation. as fresh frozen tissue preserve the nucleic acid material in a better manner as compared to paraffin fixation, it is most suitable for the molecular genetic analysis. That's why the fresh frozen tissue sample are the gold standard for DNA and RNA sequencing, especially when the strands required to be longer than 50 base pairs. And even for ISCs, fresh frozen tissue are useful as the proteins are still preserved in their native state. So these are these are some of the advantages of fresh frozen tissue. Next slide. So what are the disadvantages of the fresh frozen tissue? So for fresh frozen tissue, we require sample to be frozen as soon as it is taken out. That is, sample is collected. The sample is kept in the liquid nitrogen at as low as minus 180 degree Celsius, and this process is called as flash freezing. And such means that such facilities may not be available at all the centers and all the laboratory. So this technique is new, but it has limited availability in selected centers. Again, the fresh frozen tissue undergo rapid deterioration once the sample reaches the room temperature. That's why fresh frozen tissue requires strict temperature control. If the temperature control is not maintained, the sample quality might get deteriorated. And that's why for the storage of this fresh frozen tissue, it requires to be kept at ultra low temperature freezers at as low as minus 80 degrees Celsius temperature. And such storage is actually expensive because it requires expensive equipments and the instruments. And again, such storages are also vulnerable to situations such as power outage and mechanical failure, which can alter the temperature chain of the maintained tissue. So these are the disadvantages of the fresh frozen tissue. Next slide. So this is a slide which I have taken for comparison of the paraffin tissue and the paraffin embedded tissue and the frozen tissue. So paraffin embedded tissue, the difference is that the fixation is done prior to embedding, and in the frozen tissue, the fixation is done after sectioning. For paraffin tissue, the sectioning is done with the help of microtome, but for the frozen tissue, the sectioning is done with the help of special instrument, that is cryostat. For paraffin tissue, the advantage is that is a major advantage, that it can be stored for many years at room temperature, which makes it really very cost effective. But for the frozen tissue, the storage can be only for a short period of time, that is 1 year, and that also need to be stored at very low temperature, that is minus 80 degrees Celsius. Further advantage of paraffin tissue is that it preserves the tissue morphology, so that it can be well examined under the microscope for the morphology. But frozen tissue advantage is that it preserves the enzyme and antigen functions better, so that it can be better used for ISC purposes. Again, the limitation of paraffin tissue is that overfixation can mask the epitope, and the limitation of the frozen tissue is that ice crystal formation negatively impact the tissue structure and the architecture. Next slide. So to overcome some of these problems, both with the formalin fixation and the frozen section, there are newer fixatives developed which are formaldehyde free, and these are specifically the molecular fixative developed in the recent few years for the molecular testing. So majority of these molecular fixatives use either alcohol or acetone as a base solution, because alcohol and acetone has been shown to preserve the nucleic acid material in a better manner as compared to the formalin. But these fixatives need to be added with some other stabilizing agent to overcome the well-documented effect of shrinkage on the tissue by the such fixative like alcohol. Next slide. So some of the novel techniques which is used by the molecular fixative are like HOPE technique, which was first introduced in the 2001, which consists of a mixture of a herpes glutamic acid buffer and the acetone as a fixative. Then one such technique is universal molecular fixative, which was developed by the Department of Pathology in University of Miami, and it has used the combination of methanol-based fixative with the polyethylene glycol. Next slide. So this is a table which shows some of the newer molecular fixatives which has been developed in recent year, and which can be used when the purpose of the tissue collection is mainly for the molecular testing. Next slide. So does all these molecular fixatives actually better than the formalin fixation? Is there any data for that? So there is a study published in the American Journal of Pathology in 2004 by the Cronin et al. And they have specifically addressed this question. And in this study, they have reported that molecular friendly fixative has been demonstrated to preserve RNA and DNA in a better manner than the formalin fixed equivalent tissue. And it is almost similar to the quality which we get with the fresh frozen material. So that's why the molecular fixative can be employed when our main purpose of the tissue collection is the molecular testing. So again, although the fixation is the most important part, whether other factors can also affect the preservation of DNA and RNA, it's surely it's like that only. And some of the other factors which affect the preservation of DNA and RNA are the warm ischemia time, temperature of the fixative, pH, and method of isolation, etc. Next slide. So warm ischemia time and the cold ischemia time is one of the important factor which is required to be addressed when we purpose to do the RNA sequencing to profile the messenger RNA and the microRNA. So warm ischemia time occurs when the blood supply is cut off from the tissue during the surgery, which can cause tissue ischemia and pH changes, which can alter the quality of DNA and the RNA. And that's why the highest quality of DNA and RNA is obtained when the tissue is frozen. As soon as possible, it is taken out of the body. And even the short delay in the freezing can lead to subtle changes in the RNA expression profile, which is called as cold ischemia time, which is very important for the RNA sequencing. Next slide. So this is the last slide. Here means many times we have only small amount of paraffin block available, which is stored for a long period of time, or we have only limited H&E stain slide available for us for the molecular testing. So whether molecular testing can be improved with some of the novel platforms for molecular testing available. So just to address this specific issue, the recent publication was done in the Journal of Molecular Diagnostics by the Z et al, and they have reported their results with some these novel technique of molecular sequencing, that is H sequencing. So H sequencing is a novel genomic analysis platform which combines the quantitative nuclease protection assay technology with the next generation sequencing. So in this H sequencing, with the use of this H sequencing, in this paper they have reported that genomic profile and the biomarker data can be retrieved even from the small and limited tissue, even with the help of only small quantity of H&E slide and small quantity of paraffin tumor samples. So they have in this paper they have mentioned that this small amount of tissue can be used as a meaningful proxy for the genomic profiling in place of unstained slides. So next slide. So in summary, for molecular testing, fresh frozen tissue is the best, but this technique may not be available at all the centers. Molecular fixative should be preferred over the formalin when our purpose of tissue collection is mainly molecular testing. Factors other than fixations also need to be optimized, like warm ischemia and cold ischemia time, and newer techniques need to be developed for gene expression profiling when the tissue is limited, like Nile study and whatever results we have available with the Guardian 360 liquid biopsy study. Next slide. Thank you.
Thank you, Dr. Sameer. That was a very informative presentation, as acknowledged by many of the participants. What we can understand as a summary is we want adequate tissue, adequate RNA, adequate material for genetic processing. So we can do it by two ways: either improve the quality of tissue or improve the way we test, improve the precision of testing. So these are the two ways. So we will have a question answer session right now. So I was just asking you, Dr. Sameer. So you mentioned very precisely the steps that were involved in processing tissue. So often, as a medical oncologist, we do a core biopsy from the lung and we send to the lab, and the pathologist will say there is no adequate tissue. So is this inadequate tissue due to inappropriate biopsy, or is it due to inappropriate processing by the lab? So what do you think? What is the importance of training the laboratory professionals in preserving these precious tissues, how to process them? So your comments on this?
Yes, sir. Means both the factors are important, because the tissue form where the biopsy has been taken and how it has been processed. So definitely the tissue needs to be taken from the representative area of the tumor. If we take a tissue from the necrotic area, definitely the pathologist will say it is a necrotic material. We don't have any adequate number of tumor cells available. So yesterday we were discussing, we need at least adequate number of tumor cells, viable tumor cells, more than 10%, to be further processed for the molecular testing. So again, both the factors are important. Tissue processing is also important, and the area from where the biopsy is taken and the adequacy of the biopsy material is also very important.
Correct. So most important is the pathologist should be aware of which clinical context the patient he is dealing with. If he doesn't know the clinical information, then he may be missing whether it is a normal tissue, whether it is a pathological tissue. So that is one important thing where the pathologist needs to know the context in which he is dealing the tissue. Okay. So after biopsy, so even today in some centers, we have a misconception that we take the tissue, and if you put in formalin, it gets destroyed. We cannot use it for histopathological examination or molecular testing. So even today, few of us send in normal saline. So what is your comment on that? So is normal saline adequate or it's not adequate?
No, sir. Normal saline is not adequate for our histopathological examination. It must be sent in 10% formalin for proper fixation. Normal saline basically we use for the microbiological testing. So if your intent is to test for microbiological culture like AFB culture, bacterial culture, or staining, fungal stain, something like that, it can be sent in normal saline. That is a way forward for the microbiological testing. It should be sent in normal saline only but for the histopathological examination, it should be sent always in a 10% formalin only.
Correct. So as you very correctly mentioned that we want to prevent the denaturation, we want to have the tissue intact. So we must send in 10% formalin. And this is a question to follow on from Dr. Sabyasachi. So, so how do we test the quality of formalin buffer? So again, this is sort of a more of a manufacturing question. So we want a neutral buffer, and the pH is around 7, and that is the way we deal with it. Somebody want to add anything on this?
Sir, actually, that is a very technical question, but I want to highlight one point here. Buffering is very important because if you don't buffer the solution, it can form the formic acid from the formaldehyde, which can again degrade the quality of the DNA extracted. So we need to make a proper neutral buffer solution so that formic acid is not formed and proper DNA material is preserved.
That's the reason why the pH is 7 and it is named as neutral
but how
buffer.
to test the quality, actually I'm not aware.
I think it's manufactured and it is tested, and that's how it comes in bottle. And the pH is 7 and it is neutral. So that is about it. So from Dr. Pramod Kumar, so at the time of formalin solution, formalin solution gets turbid, precipitate at the bottle over time. So should we discard it or we can use it after remixing? Samir, again, it is technical.
Again,
I understand we are medical oncologists.
I think if we have any pathologist available.
I think Anuradha ma'am is there. Anyone of you can comment. Anuradha ma'am, you're there? Should be discarded. Okay. So ma'am says that if the formalin is not good looking turbid, we must discard it because the pH is changed. Okay.
Right.
Okay, next question. Yeah. So can biopsy imprint slide dip in formalin before sending? Samir, you have any idea on?
Again, not.
This is a very technical question.
Right.
Anuradha ma'am, can you have any word on that? If for imprint, should we dip in formalin?
Anuradha ma'am, I've unmuted you. You can unmute yourself.
Okay. So I think it was a very technical question. We need to look into these finer details. So we were so our whole purpose was, yes ma'am, you're there.
Yeah. So yes, I don't think so we should treat with formaldehyde or formalin because we are further going to stain the slides with HNE, and also they may again give a hindrance to the nucleus and all those things, because ultimately we are looking for the HNE. But yes, if you're going to process it, those for the NGS testing and all, removing the DNA for the DNA extraction and all, then yes, we can fix it with the regular 10% formalin buffer.
Okay.
Can dip it into that.
Okay. So ma'am, this is one more follow-up question. What is this 2+2 fixation in the lab? This is sort of the very technical things for a medical oncologist. It's difficult. So we were trying to convey how to process in the medical oncologist in the perspective. However, we need to address these final details. I understand. Ma'am, anything you want to add? Samir, you want to add anything on this?
No, I'm not aware of
Any
this.
pathologist in the group can add if...
2+2. No, I'm not aware.
Okay.
So this mainly deals with the temperature changes which we do during fixation. So they have given up a specific protocol regarding that. So, but it is only mainly a theoretical, means nobody I think use at present in their routine practice that 2+2 fixation. But it has shown to reduce the fixation time by almost 20 hours. So, maybe useful if further details we can get, and if we can use it in routine clinical practice, so that we can have a rapid testing reports available for our patients.
Okay, so Samir, you can have a last comment on fresh frozen versus FFPE. So how practical it is, which is superior, which is inferior. So what's the way to go?
So definitely for molecular testing, fresh frozen tissue is superior as compared to formalin fixed paraffin embedded tissue. But technically, this facility is not available at most of the center, and it is actually a costly procedure. Also, it requires a lot of expertise and a lot of instruments and a lot of facilities to be placed in for practicing this in routine way. So that's why definitely fresh frozen, if it is available, it can be practiced for the molecular testing. But if it is not available, then we have to go forward with our routine procedure of tissue processing.
Can I come over?
Yes, ma'am. Yes, ma'am.
Yeah, so actually it is the most fresh frozen tissue is the most preferable one. But as soon as you get the tissue, suppose if it is into practice, we have to transfer it into RNA ladder immediately. So we have to keep the bottles in the operation theater where the surgeon can take the tissue and he can transfer it immediately in the RNA ladder, and that will be the wonderful thing to have it, like for the NGS.